Good morning and welcome to the New York State Center of Excellence for Alzheimer's Disease educational session. We will review a few slides with explanation, and if you have any questions, please contact our center. Let's talk about treatment now. What can we do for patients with Alzheimer's disease or amnestic mild cognitive impairment? So for Alzheimer's disease, the treatment options are cholinesterase inhibitors, NMDA receptor antagonists, vitamin E and C, and we have to modify the risk factors and correct the causes. So let's look at amnestic mild cognitive impairment first. FDA has not approved any of the cholinesterase inhibitors for amnestic MCI, and it was not approved because what happens is amnestic MCI is still a mixed group. Some people will progress to Alzheimer's, some people will move backwards to normal, some people will stay in amnestic MCI. So it would be overtreatment in some cases. These studies were all done before the biomarkers were available. So now with the biomarkers, probably these studies will be revisited and redone. But even from these studies, what we see is that if somebody is treated with donepezil at the amnestic MCI stage, then the conversion to AD is less over the first 3 years than if somebody is on placebo. But the observation was that at 3 years, they kind of catch up and they have the same type of Alzheimer's disease. Now, this stage was really not evaluated into the severity of the Alzheimer's disease, just the conversion. So it delays conversion within 3 years, but at 3 years, about the same number of people have converted. So I think in my mind that what it says, if somebody has amnestic MCI and they have it because of AD, in 3 years they will convert no matter what you do. But you can delay that with the donepezil. So it's not FDA approved. However, after risk stratification, actually, I use it. So if somebody has temporal lobe atrophy, hippocampal atrophy already corresponding to the measured memory impairment, I measure it with neuropsych. It looks clear. It's an episodic memory. They learn well, no recall at delay, and they have a temporal lobe atrophy. They have Alzheimer's. They are on their way. So I start treatment after this type of risk stratification. If I have amyloid PET, if I have CSF biomarkers, positive for amyloid, I will also start it. But in general, if you just suspect amnestic MCI, if you have not measured it, and if you don't have really good biomarkers, then probably it's not good to start. The other factor is ApoE4. So ApoE4 is the biggest genetic risk factor for Alzheimer's, but it's a risk factor. It does not cause the disease. It increases the risk, and usually you have earlier onset. So what we see here is that if you have no ApoE4, then this is your conversion rate. If you have ApoE4, then this is your conversion rate over the first 3 years, 36 months. If you treat the ApoE4 group with donepezil, then they shift up towards the group that has no ApoE4. So with donepezil, you kind of correct this genetic risk for conversion by using cholinesterase inhibitors. So if I know somebody's ApoE4 genotype, I will also start treating them earlier. So cholinesterase inhibitors work. These are all the studies that have been done. 90% of them showed effect. It's not magic, it's not huge, but all these were measured over a short period of time. So what we see that it has an effect over the first 1 to 2 years, because that's what we can reasonably measure in a clinical trial. However, now with the standard of care that everybody is on cholinesterase inhibitors, what we are seeing is that actually the whole disease course, the natural history, if you will, of the disease changed. So the decline in MMSE scores is not 2 to 3 points a year, but it went down to 1 to 2 points a year, or sometimes just 1 point a year. So cholinesterase inhibitors work. However, you have to set realistic expectations for the effect of these drugs for yourself and for your patient. Patients do not get better. Very few patients in the big studies got a little bit better over the first year and then they catch up. What really happens you change the slope of decline, and that has been shown consistently in every clinical trial. You change the slope of decline in cognition and the slope of decline in activities of daily living or functional abilities. So when you start it, you have to believe it, that the clinical trials showed it repeatedly, and this is what's going to happen. The natural history has showed it as it's modified by the cholinesterase inhibitor. And you have to tell your patient that you will not get better. But what we are doing, we are decreasing your slope of decline. So you will be as good as you are for as long as possible. And that they understand. And then they comply with your treatment. If you stop it after some time, they can have very severe deterioration from stopping the drug. So the approach should be that you have a firm diagnosis. You go all the way. I have memory problems. Oh, let's try donepezil. That's not an approach. I have memory problems. Let's measure it. Let's say, is it early AD or is it amnestic MCI? Is it high risk for conversion amnestic MCI? If it's AD, we need to start treatment. We have to work together to get you on the treatment. Titration doesn't work. Do slower titration. It's not that you have to get them on the drug tomorrow. You have to get them on the drug within a reasonable 1 to 2 months period. So if they don't tolerate the 5, cut it in half. Give them 2.5 for a couple of weeks and then go to 5. The side effects of nausea, vomiting, and diarrhea are often mild. Maybe 2 to 5% of people will experience any of those. If you go slow, it's going to be minimal. And the body gets used to it, so it's a transient problem. It's going to be resolved. If somebody really does not tolerate the donepezil, you can go to Exelon patch. And that brings us to the types of cholinesterase inhibitors. So all of them have the nausea, vomiting, diarrhea, because we are faulty design. Acetylcholine is a neurotransmitter in our GI system, and acetylcholine is the neurotransmitter for our memory. So donepezil, rivastigmine, and galantamine are the options. Donepezil, once a day, high dose studied, it can cause some vivid dreams. So despite the insert saying use it at night, just use it in the morning, then you avoid the nightmares. They will never do a clinical trial to prove this. And all clinical trials for CNS drugs will have evening dosing because what they are afraid of is sedation, right? But now we know from experience that in some people it can cause bad dreams. So just give it in the morning, they will be fine. There's no sedation with this drug. Rivastigmine, it has a little bit more side effects if you give PO, especially cardiac side effects. The patch is actually pretty good because it does not have the cardiac side effects as much and decreases these GI symptoms. But you cannot reach as higher level or relative level as with donepezil. Galantamine was a great idea, that it's going to work on nicotinic receptors too. It's going to have additional benefits. So the clinical trials prove that there's no additional benefit, but there's increased cardiac death. So I usually shy away from galantamine unless it's really our final choice. The person did not tolerate any of the other drugs. I can tell you that if you work with the patient, I have maybe 3 people who I could not get on a cholinesterase inhibitor. And those 3 actually were all men, and they had a idiosyncratic reaction that they became aggressive on the drug. So that's something that I can't fix. They became aggressive. We tried it 3 times, because if you suspect the reaction, you take them off and then you try it again. Do you get the same reaction, right? So 3 people I could not get on. Everybody else, if you work with them, they get on the drug. Memantine. So memantine is approved for moderate to severe Alzheimer's disease. It only has effect on function, not on cognition. So don't start memantine when somebody says, I have memory problems. The right way to do it is make the correct diagnosis, start the cholinesterase inhibitor, and when they go across the threshold of moderate stage dementia, that's when you start the memantine. And it mainly has the functional impact. So it's approved for moderate to severe Alzheimer's, not a lot of side effects. It does seem to have behavioral symptoms, however, we were not able to show it in clinical trials. there was only one observational study that used both at the same time. So we really don't know starting two of them together is better or not. It hasn't been studied, and since the outcome measure is the change of slope, you really can't measure that in your person. So I think it's better to just stagger it. Also, memantine will also exclude if your patient wants to be in a clinical trial because they want to do everything. And now there's some hope. Nature published a new clinical trial on a monoclonal antibody, aducanumab, which actually cleaned up the brain. So for all of these trials, memantine will exclude them. So if you start it too early, when it's not indicated, you are excluding them for clinical trials. Vitamin E. So vitamin E was the magic drug about 15 years ago. It was good for everything. And what we see is that actually in Alzheimer's, it does have a little bit of benefit. Vitamin E decreases the slope of decline. It does not prolong life, but it decreases the slope of decline. However, when you look at vitamin E, then there's an increased all-cause mortality when you look at all kinds of clinical trials. So because it was actually the magic drug 15 years ago, we used it for everything. We used it for heart disease, for Parkinson's, for name it. We used it for everything. And they went back and looked at the safety data on those clinical trials, and it really increased all-cause mortality. So even a vitamin is not always safe, and you don't know. Not to mention all those supplements that these people might be taking. So on the supplements, the take on the supplements, it's not regulated. So you don't have measured benefit, and you don't have measured risk. So you don't have a risk-benefit ratio. Is that something you want to recommend to your patient? No, and it costs a lot of money. And then they come up with this thing that, oh, but on the internet there was this really cool brain, and it was cleaned up because I was taking coconut oil, because that person was taking coconut oil. And they can make these really nice graphics and cartoons and movies now, and people believe in it. So you have to be there for your patient and explain that that bag of supplements, $2,000 worth, it's not helping you probably, and it may even cause harm. So if they are really insistent, I tell them you can pick one favorite, take that one, but don't take all of them. They also start to kind of have the same ingredients, so it's a mess. So what happened with the vitamin E thing is that we say that this is where risk equals benefit. So everything above it, the risk is more, and everything below it, the risk is less than the benefit. So Alzheimer's is actually down here, but if they have any other thing like cardiac disease, diabetes, Parkinson's, then the risk outweighs the benefit. So I usually don't use vitamin E. Now, discontinuation of drug. So I just heard that the Geriatric Society's guidelines is to put people on the drug, and if there's no improvement in 6 weeks, stop the drug. That's not an outcome measure that we can measure. It's change of slope of decline. Now, if somebody was on the drug, we knew it from clinical practice and experience that when you stop it, they can get worse. They can drop 5 points on the MMSE. It doesn't happen overnight. So if somebody needs surgery and they cannot take their donepezil for 5 days because they are MPO and not swallowing and they have to drop half it, that's fine. If they can take it for 2 weeks, that's fine. But don't leave them off their drug when they go home. Whenever they can swallow, they should go back on. So with these declines, we usually see after 4 to 6 weeks of the drug. And they can drop 5 points on the MMSE. They can go from mild to moderate, from driving to no driving, from being independent to 24/7 supervision. And you cannot turn it back. So don't stop the drug. Now, the Brits, they really care about how they spend their healthcare dollars. They did a randomized discontinuation study. And what they see here, so they have 4 arms. These were people with moderate to severe Alzheimer's living in the community. They were all on donepezil at least for 3 months. And then they said, okay, we will randomize. Continue donepezil, discontinue donepezil, discontinue donepezil and start memantine, continue donepezil and start memantine. And these are the arms here. So the placebo is this one. And the dual therapy is this one. So the dual, and this is cognition, so the higher number is better. lower number is worse. So dual therapy or single therapy were very similar. But if you stopped it, they were statistically significantly worse, even in a short period of time, 52 weeks. If you look at functional, then the improvement is this way, the direction of improvement. So functional score, the higher score is worse. Now this is your group that was discontinued, and this is the group which was on dual therapy. So you don't stop it, even at the end. So for treatment, firm diagnosis, treatment, work with the patient, and it's a lifelong commitment.